Well, good afternoon, and thank you for joining us. You've landed at the CAF COVID Weekly Roundup. My name's Jason Belden. I'm the Director of Emergency Preparedness for CAF. Today is June 11th, 2021. It's 1 o'clock in the afternoon, and we're going to cover a number of topics today. The AFL's specific to skilled nursing facilities. The testing is a big one. We'll cover that in depth for sure. I don't have a slide on NHSN. It's more of an update, and I'll talk about some of our concerns. I'll go over the Cal OSHA emergency standards. They changed again. Less than a week after I presented last week, they changed. Since that time, we'll go over that. And the CDC has adjusted their travel advisories. I didn't create a new slide. I left all the information from the old slide, but it has the links that takes you to the currently updated information. So we'll get to all that as we progress through. As always, you can join, view most of CAF's coronavirus resources at that website there, caf.org/resources/coronavirus, and it should have most of the information that we collect from different agencies there. All right. I realize we have folks still trickling in, and so I'll try to go slowly before we get to the meat of the presentation. Just a general introduction, the speakers' opinions expressed on this webinar are their own. They may not reflect CAF's official position. Where it differs, I'll try to highlight that. We are a grant-funded program that's brought to you by grants through the Department of Public Health, as well as the Los Angeles County EMS Agency. I have no personal financial conflicts. I'm employed by CAF, and this webinar won't be covering any sales material. The intent of the webinar is to give you a situational report for activities that happen during the week which will impact your operations for the current coronavirus response or COVID response. We'll do some forecasting where we can, where we anticipate seeing things come down the line. We try to be the best we can about that, and obviously sometimes we get either bad information or government agencies change direction. We try to be as accurate as we can with the forecasting, but we do that where we can, as well as highlighting best practices in operations. We try to bring those to you as well. All right, so we got a few more people piling in. I want to hop to this. This is probably top of most of your minds, and that's the AFL 20-53.4. This is the testing guidance for healthcare personnel and residents. There's a lot of meat in this AFL, and there are really nuanced things that could trip you up. So you may even have to reread this AFL like a bunch of times to be able to get it. It took me a while to kind of get through the nuances of it. But let's start with the most important thing, or the biggest news, is that SNFs may discontinue routine diagnostic screening testing for any asymptomatic healthcare personnel who are fully vaccinated and they work in a facility where 70% of residents and 70% of healthcare professionals are fully vaccinated. We'll get into what is considered a resident and what is considered a healthcare professional for the purposes of this AFL. Dr. Epson gave me some written responses based on questions that were answered on the HSAG call, and so I'll go over that because that depth was not in the AFL. And so, even though it's not written in there, we're under the assumption that this is how it's going to be surveyed. And so, in the AFL, it said 70% of residents and healthcare workers. And if you read it, it was up in the air as to, one, is it greater than 70% or is it 70% or greater? Well, one, we know it's 70% or greater. So if you hit the 70% mark, you're okay. But it would also lead you to believe that it could be a combination of the two to lead to the 70%, but that is not the case. It is 70% in both categories, and if either one of them drops below that 70% metric, then you would have to fall back to the previous testing guidance. or testing frequency, I should say, for the vaccinated staff. What we do know is the weekly cadence is going to stay, and more than likely, it is a bit of forecasting, that weekly cadence is going to stay until there's no more testing. I can't ever see a point where they're going to go back to monthly testing that's in the CMS QSO, regardless of test positivity in the community. Testing once a month is immaterial to being able to diagnose outbreaks. It's only giving you a percent or a picture of one day a month, or a period of time during a month, and it has very little value to be able to cohort people effectively and identify outbreaks if we're only testing once a month. So it's either weekly testing or it's no testing at all. That's my guess. And I've had conversations with Dr. Epson. It's definitely going to stay weekly. We know that for sure. I just don't see a point where testing once a month is applicable or should be applicable. The testing for anybody that has symptoms is going to stay. So that's going to stay regardless of whether folks are vaccinated or unvaccinated. And testing after an exposure, confirmed exposure, that's going to stay, as well as response testing is going to include those folks that have been vaccinated, regardless of whether they have symptoms or not. If you're in an outbreak response testing, you're going to test everybody. There was language in there, and I highlighted this: must. Anytime it says must means that they're going to verify that you're doing this. So you must daily monitor the percentage of residents and healthcare professionals that are fully vaccinated. And that could be, using those tracking sheets that the NHSN has prepared. I think that's probably the easiest way to do it, but maybe you have your own internal tracking sheet. But you're going to have to develop one that has a daily kind of log of what residents and healthcare professionals are vaccinated on a daily basis. Now, we'll talk about reporting that in a second, but just what you need to monitor is doing that on a daily basis. Now, if at any point you drop below that 70% level, what you're supposed to do is resume testing of all vaccinated staff. So put them back into the pool within 1 week. So if you drop below 70% of the resident threshold or the patient or the staff threshold, you're going to have to go back to testing those folks. Once you've dropped below 70%, if you're going to adjust going back up, let's say you drop below 70% and it's a monetary or a momentary blip, or less than a week, let's say. You've got 2 weeks. So once you go back to testing all staff, you need to continue that testing for a minimum of 2 weeks. Once you go back above the 70% threshold, then you can adjust the testing 1 week after that. Talk about confusing. It's going to be a lot for you guys to kind of monitor this stuff. I'm sorry to laugh. It's not funny. It's going to be really difficult. But yeah, I apologize for this one, guys. When we got drafted the AFL for the testing, it did not have this language in it, and certainly if it did, we would have given them a lot of comment about how easy this is or how difficult it will be to implement, especially with the daily kind of assumption. So I want to talk about the changes to newly admitted or readmitted residents. This has been verbalized on the calls, but it wasn't really kind of captured in language. Now we have it in the AFL, so we know exactly what we're talking about here. So for anybody that's fully vaccinated, that is coming in either newly admitted or readmitted, they're no longer required to quarantine, provided they've had no prolonged close contact with a confirmed positive case. And that prolonged close contact can be defined as a total of 15 minutes over a 24-hour period. So it's a fairly specific term as to what they define as a prolonged close contact. Testing of everybody else is still required, meaning all newly admitted or readmitted residents are still required, and fully vaccinated folks are still required to be tested. Testing of, I'm sorry, the fully vaccinated folks do not need to be tested, but the testing of all the either partially or unvaccinated folks needs to continue to happen. Now, they can be tested at the acute, and if they are, and it's 3 days prior to their discharge, you can use that test. You can also use the days at the hospital in determining that 14-day window, provided the hospital has no outbreak and you've been in conversations with the infection preventionist from the hospital or the health department to confirm that there are no existing outbreaks at the hospital. You can count those days prior at the acute. It's just that the test has to come within that 3 days prior to discharge. Any unvaccinated or partially vaccinated resident must quarantine for the 14 days of last exposure. And they're considering that last exposure as them being in the community rather than being at the hospital. But obviously, if the hospital has an outbreak, the infection preventionist or the health department says, no, they've got active cases and they're in response testing at their hospital, then obviously we'd put that person start their 14 days from the day that they arrive at our facility. Any readmits that come back after 24 hours must be quarantined for 14 days if they're not fully vaccinated. And that was in the visitation AFL, but they just kind of, reinforced that here. The testing and quarantine are not required for residents who have tested positive and recovered. So those that are within that 90-day window, like they've tested positive, they've been removed from transmission-based precautions. They've met that criteria for the removal of those transmission-based precautions. In between that time and the 90-day mark, that's considered COVID recovered. Testing or quarantine for those residents are not required. All right, so they did further expand what their expectations or clarify their expectations on response testing. And so just to be clear, response testing happens when anytime you determine there's one or more positive cases in a staff or resident. So any positive case in the facility, you're going to begin response testing. That testing can be performed with either antigen or PCR testing. The test must be performed upon discovery. So the minute you determine a positive case in your facility, you would immediately begin response testing. Test them once, and then test them every 3 to 7 days until you go 2 weeks with no positive cases. And then you can go back to surveillance testing or screening testing, I'm sorry. For fully vaccinated residents who test positive and they remain asymptomatic, they should be isolated and observed for the development of symptoms while additional evaluation is conducted in consultation with your local health department. So, I'm not sure how likely the health department is going to be to remove those folks out of isolation. I don't think that's going to happen. I think they're, out of an abundance of caution, most of them are going to say, even for the vaccinated residents who are positive, even if they stay asymptomatic, they should be isolated for a period of time for the observation of symptom development. I don't know that for sure. I've not talked to everybody, but I do anticipate this is something you would have to really get individual consultation with your health department to be able to get those folks out of isolation. For anybody else, all the non-vaccinated or partially vaccinated folks, they all go to the quote unquote red area. And I'm going to describe that on the next slide. But for the duration of the isolation period, however long that may be, everybody else goes in that period. Anybody that's negative but has exposure must stay in their quote unquote yellow area. And we're not calling it a zone now, we're calling it an area. And what do they consider exposed? Any resident that was on the unit or wing where a case was identified in a resident or a staff are considered exposed and should remain in their current room unless sufficient private rooms are available. So that doesn't mean that we would take folks and move them around the building if the folks in a wing were exposed. We would now have that be our yellow area. Anybody that's negative without exposure can stay, or they're COVID recovered within that 90 days, they can stay in the quote unquote green area. All right, so they have redefined what a red area is, and I'll talk about, how, in light of the fact that we're not required to have a mitigation plan now, or they stopped doing the mitigation plan surveys, they still require most of the elements of the mitigation plan. So we'll cover that in a second. But in terms of what a red area should be, maybe the last little bullet point here is the most important, but you must keep this warm shutdown or ready to go, or whatever you want to call it. You must be ready to implement it, but it does not need to be dedicated space set up, just static waiting for folks to use the space. I apologize, God, my dog's barking. The COVID-19 positive cohort should be housed in a separate area of the facility. So if you have a big outbreak, obviously you kind of know what to do if you've already had one of those. And you need to have dedicated staff who provide care for residents in those areas. Now, in the case where you get one positive case, it is impossible. It is impossible for you to separate care, to have all dedicated staff for just one resident. It's not achievable. I said that a million times to the folks at CDPH. You just can't do it. It's incredibly difficult just in the yellow zone to be able to monitor and manage that. But we can't do it with just one person. So, the law really says that we're referring providers, and I'm anxious to get back to that point where we can transfer one specific person with an airborne infectious disease out to a hospital. And I think we're getting to that point, guys, but I don't know that we're there yet. In lieu of that, I don't know what to do about staffing one red zone. I think, if you talk to them, offline, they understand that you can't staff it separately, but getting that into language is not great. And this is going to cause you a bunch of hassle with surveyors, wanting to make sure that all this is set up and separate. You just have to say, look, this is what we have to do to be able to share these staff. These are our procedures, and these are the PPE requirements, and these are the accommodations to safely secure that space, even though you have to share staff. I think if you can show them that you did everything you can do to protect the remainder of the residents in the building outside of having distinct staff for it, maybe even schedule the staffing around having the care activities occur for that person towards their end of their shift, so they don't have to go back or before their lunch break or things like that, where they may not carry contaminants from that space into the green space. But it's going to be difficult for you to manage that, and I got to be honest, I'm not sure if you could do it with just one person. Maybe if you had 4 or 5, it'd make it easier. Any housing of symptomatic individuals undergoing COVID testing, if available, a private room should be prioritized for anybody that's exhibiting symptoms. I know private rooms are not available in abundance, but if you do have that ability and you have somebody that is that's symptomatic, let's reserve that space for those folks. Anybody that's been previously positive within the last 90 days does not have to be retested unless they are symptomatic. If they're symptomatic, it says in the AFL, they want you to have them tested again. What the test is going to show you is that they're positive. I don't know what the point of it is, but the symptomatic nature of this, I think, really gives them pause that maybe these folks could still be, passing along the virus to other folks. In terms of quarantine, isolation, and transmission-based precautions for anybody. You may consider that in consultation with your medical director or an infection control expert, especially in the event that symptoms develop within those 14 days. So if somebody's been vaccinated or they've been previously positive, I think that really the goal is to get them in quarantine or isolation for 14 days, even though they've been previously positive. All right, so duration of isolation of residents and work exclusion for staff who test positive. And so in these symptomatic residents who test positive need to remain in isolation. This is just a recognition. I don't think this has changed. It's 10 days since symptom onset, 24 hours have passed since resolution of fever and all other symptoms have been resolved. And consider extending the time for severely immunocompromised folks up to 20 days. Those conditions also apply for staff. We'll go over that in a second. Asymptomatic residents who have not been fully vaccinated should be isolated for 10 days minimum, it says. Now, this is not the same as a new admit. This is somebody that has been tested positive, right? We know they're positive, so they need to be isolated, but the isolation is a minimum of 10 days. If within those 10 days symptoms develop, then you're going to have to start that clock again, and that 10 days won't start until the symptoms, 10 days since the symptom onset, and then 24 hours have passed since the resolution of their fever. So I'm not certain that has changed much, but definitely want to make sure that we isolate those folks for the minimum amount required. Fully vaccinated residents who test positive and are asymptomatic should still be isolated. So that means that you're going to observe them for symptom development and call the health department, your local health department, to confer with them on the reduction of that isolation period. Now, if there's no symptoms and the resident's fully vaccinated, I think these are the ones where the health department may be more inclined to remove them from isolation. But it does require some kind of coordination with your health department to do that. All right. Oops, sorry, I went one too far. All right, here we go. Duration of isolation, and this is for the staff. So it's same thing with the staff, 10 days symptom onset, 24 hours past since resolution of fever, extending the time for severely immunocompromised folks up to 20 days. So staff that are not fully vaccinated who test positive and are asymptomatic should be excluded for work for that 10 days. If during that 10 days they develop symptoms, then the 10 days would start from the symptom onset, and they will need to have 24 hours pass without a fever before they can come back, and all other symptoms have to be resolved. Any fully vaccinated staff who test positive and are asymptomatic should still be excluded from work and observed for development of symptoms, but you can consult with the local health department about return to work. It does go on to state if staff shortages are present, asymptomatic fully vaccinated can continue to work according to the CDC guidance on mitigating staffing shortages or strategies to mitigate staffing shortages. And that link there is to the most recent guidance from CDC on the return to work for vaccinated asymptomatic healthcare workers. All right, so in terms of how do we report these results, we know that that they want us to kind of report or keep, kind of daily stuff on the daily information on who's been vaccinated or not, but obviously there's reporting requirements around testing. And so they clarified that they finally, kind of put in language the allowances if you use the antigen test. Now, we know that if you use the antigen test, you have to use it a little bit more frequently. You have to do twice a week versus once a week. But the good news is they put in the guidance now that you do not need to report non-positive reports or results. So if you do these tests and you get all negatives, or you get indeterminate tests that are not clear positives, you do not have to report those. And that was a big barrier to why people really didn't want to do this, because if you had to report hundreds of tests, twice or more frequently a week, it becomes labor intensive, let's put it that way. But if you do get a positive, those positives must be reported within 8 hours to CalReady. And during survey, if you're using these devices, the surveyor is going to want to see documentation of how you're complying with the CLIA reporting requirements. In other words, documentation that shows that you're submitting any positive results directly to CLIA. And the link on the top takes you to the new antigen allowances. Any documentation that you keep to, kind of show your proof of testing needs to kind of contain all of these elements. Any symptomatic staff or residents, when they're tested, the time and date of signs and symptoms, the testing date and the results of those tests, and the actions that you guys took as a result of the positive tests in the symptomatic folks. Document the date of the first case, the date of any other staff, or date of all other staff and residents that are tested, dates that they're retested, and the results of all cases. Provide documentation of procedures for addressing staff and resident refusal for testing. So if you have people that refuse, I'm not sure how many this is, but if you do have folks, you're going to have to develop some procedures on how you deal with resident refusal or staff refusal of testing. If you cannot obtain test results within 48 hours, I saw there were a couple questions on the HSEC call about people that were still not getting their PCR test back within that 48-hour windows. If that's your case, guys, you got to shop labs. There's no reason your lab should take that long. There's lots of other ones out there that can do it within 48 hours. I don't want to throw your company under the bus, but if that's you, something's going on there. We need to step that up. But anyways, if you cannot obtain test results, you're going to have to keep that documentation of your efforts. One, to source quicker testing. How many other labs did you call? Did you try anybody else? As well as, obviously documentation on the laboratory you're currently using. But I just think the opportunity is out there for you to find more robust testing services for those that's needed. And the link to the California laboratory, the task force, the lab task force, I'm drawing a blank on the link now. But if you do COVID testing California and you do a Google search for it, you should be able to pull up the CDPH website, and that has a pretty comprehensive list of labs that can get this done quicker than that. Or you can contract with the state lab down in Valencia as well. All right. Like I said, mitigation plans are not being surveyed to, but actions taken as a result of these positive tests use all of the same principles. Like cohorting principles are the same as they were in the mitigation plan. They're just not calling it a zone now, they're calling it an area, which makes sense because we're not going to have static areas set up. So or static zones set up, they should just be an area, and we'll probably have to, the area may move depending on where the positive case shows up in your building. And I think that's probably more applicable. We hope when we do have a positive case, it's 1 or 2, not 40 or 50. That's the hope anyways, it's not a guarantee. But we still need to keep the strategies that we have in place to reduce risk. And we really, if I didn't mention this, and the AFL really kind of pushes, it's a continual process for us as providers to try to work on our staff and our residents to get them to get vaccinated. The best advice I can get, and my hope is maybe this drives some of your staff to getting vaccinated if they haven't been. They go, oh, I don't have to test now. If we can get enough of us vaccinated, that's certainly an area that you can highlight to folks. If we can get 70% of our staff above this thing. Monitoring of residents. I know I've had a couple offline questions about this week. The monitoring of residents must continue. That has not changed. That's in the CMS QSO. And I don't see that changing. They're still going to, cite most of that stuff under the F80 tag, I think it is. And symptom development needs to factor in new risks. So that link there, I don't know if you guys are a part of the Health Alert Network for CDC. I know facilities in Los Angeles sent out a health alert on new RSV outbreaks. And so that link is to a description of the health alert for RSV outbreaks. They're mostly in the southern parts of the U.S. now, but they are happening in our space, in the skilled nursing sector. And so there were specific kind of guidance in that news announcement for kind of what tests to look at to do concurrently when you're doing tests for COVID, especially if somebody tests negative and they're still symptomatic. So please connect your infection prevention and preventionists up with that link. So apologize. All right, now I'm going to hop to AFL 20-89. This is the requirements for application of submitting for online distance learning nursing assistant training programs. Patty and Claire Enright are the leads on this, and Patty gave me some written comments, and forgive me guys, this is not my area of expertise, but I'm going to read her written comments, and then I'm going to encourage you to reach out to Patty if you have questions about this. I know Patty seems awfully excited about it, so my hope is this really increases our ability to get new CNAs in the door. So over the last year, CAF has been advocating for changes for easier NA and CNA workforce development. These changes under the AFL are a direct reflection of our CAF team's advocacy. The revised AFL now permits SNFs and ICFs to contract with an existing approved online NATP theory instruction. The SNF or ICFs must either develop or use the contracted online school's clinical training to conduct a clinical portion of the NATP training in their facility using their own staff. Alternative online programs. This option is available to facilities that can secure an agreement with an existing CDPH approved online NATP for theory instruction, that have the capability to teach the clinical portion using facility staff with the materials from the contracted online NATP. Or facilities have the option of developing their own clinical instruction material. However, this material must be complementary to the contracted online NATP's curriculum. It must meet state and federal requirements and must be approved by CDPH prior to its implementation. If the facility's application is approved, CDPH will issue a distinct provider identification number, consider the facility to be an NATP provider, provide the facility with an approval letter, hold the facility to the statutes, regulations, and department rules, including this AFL. So I know that was a lot. Sorry, I had to read a written description of this. But CAF will be creating a number of trainings, and this is what Patty wanted me to say. So CAF will be creating a number of trainings on how to complete a CDPH application package so you can get approval to do your own, how to get the program approval changed from hire CNA only to contract with an approved online NATP, a day-to-day breakdown of how your NAs and how to get your NAs into your workforce to provide direct patient care, how to count NA's clinical and direct patient care hours for a successful staffing audit, and how to help your NAs be successful in their certification process when you can count them in the 2.4. So there's a lot of good stuff that's going to come out of this. I know Patty and Claire are really excited. So my hope is you'll see a lot of education in the coming months about this. So hopefully that explains it. And we'll hop to Cal OSHA. And I want to thank Deb Friedman. I don't know if Deb's on this call, but Deb sent me this picture this morning. That was the first thing I looked at when I got up this morning. And it just made me laugh. So the type of headaches folks get: migraines, hypertension, stress, and trying to keep up with Cal OSHA. Yeah, and that could not be truer. So we spoke last week about Cal OSHA extending and adding to their emergency standards. Scrap that. They'd issued a press release yesterday or on the 9th that essentially said we're going to go back to the original emergency standards that were in effect, and those are going to stay in effect until further notice. So if you're currently following whatever the ETS standard was, and those employees that are not covered by your ATD standard, those folks, you don't have to make any changes for those. Hopefully you didn't start already. There's also talk that the board will consider revising the current requirements at the next meeting on June 17th. So if you obviously heard that that CDPH yesterday issued a press release basically saying that we're going to remove the requirement to have masks in most public and indoor settings. That prompted to Cal OSHA to about face and reverse course. And I got to be honest, I'm not sure where they're going to go next. I've got no indication of whether they're going to extend, how much they're going to extend this ETS, whether they're going to change it, whether they're going to lower the standards based on the CDPH kind of overarching guide for the state. I don't know. But I do know that if you have those staff that fall under that emergency standard, they need to keep doing that, but they need to do it based on the old ones, not the new ones. So, and then if you have all your employees covered by the ATD standard, once again, you're exempt from doing this. You have plenty of other requirements on the ATD side, which we all do as a part of our, the stuff in the mitigation plan and things like that. So hopefully it doesn't hit a lot of folks, but if it does, I'm sorry if you operationalize things and now you got to change it back. So. All right, I mentioned that the CDC adjusted their travel recommendations. I just wanted to keep this so you had a link, or if you didn't participate in the webinar last week, the CDC definitely has specific guidance for returning travelers from other countries that will impact your staff returning on vacation and things like that. If they're visiting a foreign country, there's definitely, depending on the country, there's very specific requirements of what they should, when they should be tested, whether they should quarantine. That self-quarantine will vary depending on their job scope. For the most of us, it's going to be a 14-day self-quarantine if you hit one of those tier 4. I even think that recommendation's in the tier 3 countries too, but I'd have to double check that. But definitely all of that is listed on those 2 recommendations. So the travel recommendations by country, you click the link, it gives you a map of the world, you click on the country and it will give you that country's specific information. All right, so I mentioned the NHSN reporting, and I want to get to that before we hop to questions. Yesterday the site went live, so nationally anybody, any member of the public can go access any information about a skilled nursing facility's vaccine rate, their testing, how many, a lot of this has been available before, but there is a public, anybody can view anybody's information now. And what it shows so far, reporting as of 5/31, so we haven't really caught up to it yet, but it shows only 175 facilities in the state that have input their vaccine information. And so it leaves like 1,000 of us still not showing up as reporting on the CDC side. That gives us a ton of concern. Now, there's a delay and a lag between when they post the information. That information was based on the week that ended on March or May 31st. So we're on a kind of like a 2-week lag between when we see this information, but it does give us pause. If you've been answering those questions on the survey this week, you know, we're hopeful that if you've conferred your rights on Monday, we're going to be able to see that number jump, or the next time they push up the information, we'll be able to see that number. What we've told CDPH and CAF has reached out to CDPH and told them, look, we're really concerned that we're out over our skis here, and we're waiting till the last minute to find out if this push-pull between the state doing these reporting and giving it to the feds, when the feds are going to be the ones that issue CMPs. We've advised them they may have to, if it turns out 900 people don't show up next Monday and they're all issued CMPs, we're gonna have to find a way to back all of that out. There's just, the issue is not on the reporting side, the issue is on the push-pull side. And so we're intimately aware of how big of a problem this could potentially be. My hope is, and please answer in the questions or chat, if you started doing your reporting for that vaccine this week, let us know if those questions have shown up on the 123 survey, and whether you're having any problems with it. And next week we'll obviously get a look at the data, and then we'll approach CDPH about that. But these CMPs are going to be like automatically assigned, is my assumption. So it's not going to be they're going to call you and go, hey, you know, I didn't see you report, can you add in? They're just going to hit you with a fine, and so we want to avoid that if we can, especially if it's an error and we need to back it out. So please be transparent and let us know immediately if you see any issues with that. All right, so that is all I had for today. There were a number of AFLs, guys, that came out. Most of them had to do with a general acute hospital or other levels of service. There's nothing specific to ICFs if you're an ICF provider that I saw come out this week. So I want to say we keep an eye on these things, but sometimes some of them sneak up on us. But this Cal OSHA thing is just a nightmare. And I anticipate that June 17th we'll get more information, and next week who knows, I'll be telling you something different. So, all right, is it required to use PCR testing, or can we do POC for rapid testing weekly? You can do the antigen tested, provided it's one of the 3 approved methods. So the BinaxNOW, cards, the Sofia Quidel, or the BD Veritor. So if you're using one of those 3, yes, you can. The frequency just has to increase to twice a week rather than once a week. So if we're supposed to monitor daily, do we only count staff that, sorry, that question cut off, let me expand. Do we only count staff that are working that day? Yes, and so I would assume the daily monitoring is of the folks that are in the building on that given day. Now you may already have figured out a way to do this because of how it's going to impact your vaccinated residents and their day-to-day activities or group activities, communal activities, things like that. Hopefully that's the case. I will say in the AFL, it went out, it went, well, not in the AFL, but in the questions that were asked. Let me just get this question, because there was a question that was asked on the webinar or a conference call about similar to this, and to achieve the, here, I'll give you the question, because I think this is going to help a bunch of folks. So to achieve the 70% vaccination goal for staff, who do you consider staff? Is it anybody on the payroll? Or is it anybody that's got contract services or things like that? Here's Dr. Epson's answer, and it's incredibly broad. So the healthcare professional or staff is defined broadly, includes everyone working in the facility in a given week. Similar to how SNFs will reporting vaccination status and coverage for a given week for the NHSN requirement, use the same pool of staff that you're reporting in the CDPH daily and weekly survey and into NHSN. Include anyone who has the potential to be exposed or to expose others to COVID-19 in the facility. So yes, include registry, payroll, contract services that enter to the facility that way. So seems pretty unequivocal that that their expectation is that those contractors, those other you know, those other folks that will be in the building, yes, they're considering those for the purposes of this testing. Any updates from LA regarding adoption of the new AFL? That's a great question. Los Angeles County, I know for certain, is going to come out with their own specific guidance, and I assume that guidance is going to vary a little, maybe a lot. I'm not certain. I talked to Dr. Nee and Dr. Gounder on Wednesday, I think it was Wednesday or Thursday, and asked them, you know, when the updates were going to come out. I know they had a webinar, and they have a, you know, a kind of like a call-in session where you can call and participate on the webinar once a week. And there were a lot of questions about this because the AFL dropped right before their webinar. So the webinar wasn't specifically about that, but they did address it. I followed up with them. They are going to be issuing specific guidance. That guidance should come out soon. And after the guidance comes out, they will cover it on a Los Angeles County specific webinar. So until that time, the news from them was to continue to follow the current guidance until new guidance can be issued, since we anticipate it's going to differ a little from the CDPH side. All right, next question. Hi, Dr. Epson, Jason. Dr. Epson was unclear about how many days a facility must fall below 70% in either category before testing resumes. Is it a day, 2 days, or a week? You know, we asked that question. I thought she gave a pretty good answer in saying, I thought she led, I'm gonna have to go back and look at the notes, but I really thought she kind of encouraged that, you know, once a week you're gonna be adjusting your, even though you're counting, you know, by the day. So let's say you got one day that drops below 69 or drops to 69%, and the next day it's at 71%. Would you at the end of the week adjust because you had one day in that week that was below? And I think she basically said, you know, if throughout the week you only have one day, you're not going to go back to doing the testing. And her, I'll clarify this with her, but I think what's reasonable and what I'm going to suggest to her is that if you're that close where you are in and out, you know, under that 70%, can we just say that at the end of the week, what was the cumulative total? Did we have 70%? It's just going to make it much easier. Like I said, we didn't get a draft of this before they sent it out, and had they sent it out, most of this stuff could have got explained away. Unfortunately, they just kind of sent it out. So, if staff and resident population are above 70%, do we have to test any residents on a weekly basis? Depending on your county, I want to say that I know Los Angeles County has a requirement to test 10% of their non-vaccinated residents. I anticipate that will continue. Some other counties have specific testing guidance. Provided you're not in one of those counties that has that specific guidance, then no, as far as CDPH is concerned, residents should not be included as a part of the normal diagnostic screening. Obviously, if there's an outbreak or if you're in response testing, then obviously they're all going to be tested then. I have a facility that admits and discharges lots of patients, with more than half of the census being short-term. Yeah, that's, you know, tons of transitional care facilities, any distinct part SNF, pediatric SNF or pediatric subacute. All of you guys are going to have really difficult problems getting your resident population above 70%. I think IMDs may have issues with that. There's a lot of reasons why it wouldn't happen. If you're a transitional care facility, I do agree with Dr. Epson. I think that percentage will go up over time, as well as a DP SNF. Obviously, if you're a pediatric subacute, you can't do anything about if you have kids under 12 that they don't even have a vaccine available for them yet. So it's a little different story for you guys, but for you that have high turnover of resident population, I didn't get a good answer for Dr. Epson, and frankly, I'm not sure they're going to change that 70%. I will work on it, and I've been in contact with the hospital association since I know that the distinct part SNFs, many of them are more aligned with the hospitals. So maybe we can gather some aligned interest and try to approach CDPH about that. I do think it's going to be really difficult, but I know that there's a significant risk to those residents that have not been vaccinated. So one, obviously we want to get them vaccinated, or if they convert to vaccinated from being unvaccinated during that time, that's great. I think we can immediately put them in the green zone. Let's say they've been vaccinated, but they haven't made out the 2-week window. I think once they do that, then we can put them right into the green zone. If a non-vaccinated resident is within 90 days of being infected with COVID and has recovered fully with no symptoms, then discharged to a SNF, would they qualify to go into the green zone? Yes, they sure would. Let me expand that question in case it went further, because I apologize. This little window it gives me to look these things up, I got to maximize it to be able to get all the question out. All right. I think that was the end of that question. All right. What is the status of double masking with removal of face shields? Some staff want to wear a cloth mask under their surgical mask. If they want to, they certainly can. You know, that would be up to them. I don't know that you need to feel obligated to provide them 2 masks. Definitely 1 mask, right? We want to do that unless they have a mask they prefer. I told you my feeling about unvaccinated staff. We're getting to a point where there's very little community transmission, or I shouldn't say very little, but there's much less community transmission. As we kind of wind that down, I'm starting to think twice about, you know, handing unvaccinated folks respirators, but it's the unvaccinated folks that I'm really concerned about. I don't think we've tracked a lot of secondary transmission from folks that have been vaccinated, then getting the virus and then transmitting it to somebody else. I've not seen any studies shown that has been much, if at all, a concern. I know it was at the beginning, so I have less concern about if they've been vaccinated, what kind of mask they wear. They have to wear a mask, we know that, no doubt about it. If they want to wear 2 to make them feel more comfortable, that's great. They can certainly do that. I don't know that I would require it as an employer, though. All right, who would be the contact person for the CNA information? And so that would be Patty Owens. Her email address is powens@caf.org. So that's POWENS@CAHF.org. And Patty's super excited about this. She's probably going to be the, leading most of those educational sessions that I laid out. So she's got a lot of great information on that. All right. What is the status? Are we using the weekly percentage for testing? If we fall below 70% one day out of the week, do we have to resort to weekly testing for all AFL? Like I said, it wasn't super clear in the AFL, and maybe I misunderstood Dr. Ipson, but I really thought she said at the end of the week, we would kind of be revisiting that, even though we're tracking daily status of the vaccine coverage. What is the AFL showing the CMS could fine the facilities for not submitting their weekly report? I'll have to look that up. I don't know what the AFL is, but what I'll do after this summer, can you do me a favor and just make a note for me to get the CMS news release or the NHSN news release on the CMP fines, and then I'll post that to the forum. If you guys are not on the CAF forum, just send an email to myself or to Summer or to the info@caf.org and just ask to be put on the onto the forum, and then we post those kind of emergent notifications on the forum if you're not joined. So, all right, and I will say the forum is a CAF member only benefit. It's one of the only things that we do that's for our emergency preparedness purposes. It's a member only benefit. Now that we are not doing weekly testing of vaccinated healthcare professionals, are we required to do it at least monthly or not testing at all unless there's a positive case? And per the AFL, you wouldn't test them at all. And that's, you know, obviously get a positive case or urine response testing or that person develops symptoms, you know, you're not going to have to do it. Now, if that vaccinated healthcare professional goes to another country on vacation and they come back, depending on where they've gone, they may be recommended to test on return, but generally as a part of the screening testing, they're out and they don't have to be added back in unless those other situations occur. Can you verify whether Cal OSHA has made any concessions requiring employers to complete the respiratory clearance form prior to fit testing? No, I have not. I will say that I've talked to a number of facilities that have struggled with, you know, kind of all the components that go through that fit testing. And I'm not going to say what facility or what group of facilities, but had chosen to have their medical directors do the medical clearance. And they, you know, arranged it with their medical directors. I think that's fine. There's nothing in the Title VIII that would prevent you from doing that, and that may allow you a little easier access to getting those medical clearance forms. The only thing is we don't, you know, it's what you know as the employer is just a pass or fail. You don't want copies of their stuff, of their medical clearance form. You don't want the answers to those questions. You just want to know yes or no, did they pass or did they fail? And that's what that medical clearance is supposed to give you. All right. Thank you for advocating for the DP SNFs. Of course, you guys are skilled nursing facilities just like the rest of us. We all take care of different folks, but we take care of folks just the same. So, all right, that's the end of the questions, guys. Please, I can't encourage this enough, but if on Monday, or if you guys notice any problems with that reporting, we need to get on this quickly because it could snowball into a huge problem if CDPH doesn't do the push and NHSN doesn't get the poll. So we're going to monitor that. We're going to continue to monitor that. And if you have questions, obviously don't hesitate to reach out to us. So I think we're right at about an hour here. Hopefully you guys have a wonderful weekend. It's going to be hot up here. I think it's probably going to be awesome down in Southern California, great weather. So wherever you are, enjoy your weekend. Have a great time. Thanks. Bye-bye.